So, welcome to Case Series Part 2, a series to explain the topic with clinical cases with the Buddha's dog. Okay, so a 22-year-old male presented in emergency with confusion, drowsiness, and breathing very fast. On examination, you found that the male has dry mucous membrane and BP is at lower side 70 by 50 mmF of Hg. As I previously told you, I have to go towards the topic to explain a clinical case. Okay, so in this scenario, when the dry mucous membrane is present, BP is lower side, you take the patient history. On history, the patient you ask about, actually leading question is not asked, but I am explaining here. You ask that is patient have any gastroenteritis problem currently? Say any poison? No. Okay. So uh, after deep diving into the patient thing, in the meantime, you do a glucose check. Okay, that it is a case of it can be a case of hypoglycemia. Okay, so after checking glucose, it is around 455. After taking history, you get to know that the patient is a known case of diabetes mellitus type 1, and immediately you go to the test of ketone bodies. Okay, and ketone bodies is the present plus 3. Okay, so now you know the what is this case. This is the case of diabetic ketoacidosis. The ketone is around 3 plus and the blood glucose is 450 mg per deciliter. In this case, if a examiner previously given you that ketone is 3 plus, blood glucose is 450 and 22-year-old female breathing very fast and confusion, drowsiness, this is a clear-cut case of diabetes type 1. Normally, in mostly cases in DM type 1, it is the diabetic ketoacidosis present, but the next best step you have to do ABG. Okay, uh, to know the potassium, to know the sodium, to know the other soda bicarb, to know the pH and various other parameters of blood. Okay, then we have to go to management and other points about diabetes. Okay, so a patient, 22-year-old female or male, present in emergency with confusion, drowsiness, breathing very fast, have dry mucous membrane. We ruled out gastroenteritis. BP is falling. We ruled out gastroenteritis. After taking history, the in meantime we check for ABG and glucose. The glucose comes around 4555, and patient is a known case of diabetes type 1. The ketone body is plus 3. So next best step, we did, we checked for if this history is already given that blood glucose is 450 and ketone is 3 plus, then the next best step will be the ABG. If these two are given, if these two parameter, which parameter? Ketone and blood glucose is already given, then we go for ABG to check the blood parameters. Then we have to manage the case. Okay, in this scenario, how to manage such case? It is very easy. Just imagine the blood glucose is 450 and the patient is 22-year-old male and around 50 kg. Okay, first in the ABG we check for the sodium, potassium and different parameters. We have to check first what parameter? BP. The patient BP is around 70 by 55 mg or 50 mg. If the BP is lower side, you have to start fluid bolus infusion. Actually, fluid bolus of 500 ml in 10 to 15 minutes and repeat the BP. And if it is not, and the BP is if at low normal side, then we have to give 1 liter fluid in the 60 minutes. And if the BP is normal side, you have to give 1 liter in 60 minutes. Next 1 liter in another 60 over 120 minutes. Next 1 liter in over 4 hours. But we have to cautious while giving fluid that the urine output is very accurate and very good. Okay, and you are not giving fluid overload to the patient. Second thing, if the BP is low, you have to go for check for the bolus is BP replacing or not. Then you have to go for inotropic support. Now, after checking potassium in the ABG, after checking the potassium in the APG, uh, Potassium. There are three scenarios for the potassium ABG. Either the potassium is less than 3.5, or the potassium is 3.5 to 4.5, or the potassium is less than 5.5. In the case of potassium 5.5 or 3.5 to 4.5, you can directly inject IV insulin, regular insulin, 0.1 international unit or zero point 0.1 unit per kilogram direct IV state. Okay, that decrease the that 450 that comes down by this state dose, and then followed you have to start the infusion at the rate of 0.1 unit same per kilogram per hour. Okay, you have to start the dose if the potassium is around more than 3.5 or more than 3.5. If the potassium is less than 3.5, in these condition you have to replace KCl, okay, at the rate of 40 or 80 milliequivalent 80 मिलीक्विलेंट पर लीटर और पर ml के हिसाब से, okay, 80 milliculent per hour actually. Okay, and in these things you when you started the infusion, you have to give you have to start at 10 milliculent per hour, and for these you have to check every 2 hourly for the potassium. Okay, so also you have to give bicarbonate. Or the important thing about here, if you are injecting bicarbonate in the patient, if you are injecting bicarbonate, then you also have to check for the potassium, as bicarbonate also decreases potassium. Bicarbonate can do hypokalemia, so in these conditions also you have to check for the potassium. Okay, second thing, you have why to give bicarbonate. Normally in the normal cases bicarbonate no is indicated, but in some cases bicarbonate is indicated if in the presence of severe acidosis, arterial pH is less than 7, you have to use soda bicarb. Okay, for the first 2 hours until pH is more than 7.0. And for phosphate it is also there. If the serum phosphate is 0.32, then phosphate supplement should be considered and the serum calcium monitored. If less than 7, you have to give on less than 0.32 millimole per liter or 1 milligram per liter, you have to give phosphate and you have to give soda bicarb. Okay, this is the management of diabetic ketoacidosis. As I told you, you have to confirm the diagnosis by serum glucose and ketone bodies and metabolic acidosis. Remember, metabolic acidosis is there, should be there to call it ketoacidosis, else this will be known as ketosis only. Okay, admits to hospital, intensive care unit, and pH, if pH is less than 7 or labored respiration or impaired level of arousal, you have to go for the ICU setting. As I told you, you have to assess the serum electrolyte, acid base status, and renal function. For this, you have to do routine blood test, but first preferred ABG. Okay, replace fluid, as I told you, 2 to 3 liter of 0 point normal saline, and in the first to 3 hours, and you have to check. Okay, if you check the fluid continuously, and if you are thinking that sodium is increasing, you have to give decrease it to 0.45% NS. Second important thing, when the glucose ranges around 250 mg per deciliter in ABG or in normal checking, you have to change your glucose to 5% glucose. Okay, if this is falling, okay, on 0.45 saline, plus you have to give 50 international unit of insulin in this infusion to neutralize and stop forming ketone bodies. Okay, short acting insulin, as I told you, IV, and I told you that if the essential serum potassium less than, do not admit answer until the potassium corrected. I told you this. Assess the patient that there should be a cause of precipitating decay. Either the patient have infection, either the patient have non-compliance of the drug, either the patient have any trauma, either that is female and pregnant, patient can have cocaine in addict, or any infarction. You have to do appropriate workup for the event like culture, chest x-ray, ECG. Also you have to measure blood glucose every 1 to 2 hours and electrolyte and anion gap every 4 for first 24 hours. Monitor blood pressure, as I told you, pulse, respiration, mental status, fluid intake and output. As I told you, if the potassium is less than 5, 10 milliequivalent per hour 10 becquerel per hour के हिसाब से इन्फ्लुएंस फ्लूइड देना है, you have to correct it, and if the it is less than 3.5 you have to go to 4 to 80 milligram per hour. Okay, and it is more than 5 to 2 you do not have to supplement potassium. Bicarbonate and phosphate rule, I told you, continue above until patient is stable and your target is 150 to 200 mg deciliter and acidosis resolved. Okay, then you have to decrease the insulin and you can go patient, you can take the patient on subcute. Okay, and as soon as start on the food oral intake. Okay, so this is the management of DKA at your level and click in this clinical case. So many of you are confused about the diagnosis of diabetes. The diabetes is defined as SB1AC is more than 6.5. It is the criteria of or fasting blood glucose is 126 or 2-hour plasma glucose is more than 200 during an oral glucose tolerant test. And the main confusion is this: if the examiner asks only if the examiner is saying that the random blood sugar of a patient is to more than 200 milligram per deciliter, it is a patient of diabetes. No, along with 200 milligram per deciliter of glucose, the patients have symptoms of hyperglycemia also. Okay, screening of diabetes mellitus is advised every 3 yearly after age of 35 years. This is the ADA screening guideline. Okay, so let me make it a little bit easy for you. So in short, I can describe you like this. If patient comes, you have to do ABG, you have to check ketone bodies, you have to know history of diabetes type like 1 or 2, but more common in 1. Okay, ketone 3 plus. Okay, after you have to start check the BP and start fluid according to it. Okay, fluid or inotrop according to it. Fluid. First, in shock patient, you have to go for a fluid trial plus. Okay, you have to check for potassium. If the potassium is high, more than 5.5, if 3.4 to 5.4 or less than 3.3, you have to first inject potassium. You have to you can give insulin, IV state plus infusion of insulin, plus you have to start KCL at the rate of 10 milliculent per hour. In this case, you just have to IV state insulin plus infusion plus 2-hour check of potassium and glucose. Okay, in the case of these, you have to start first, correct, potassium to a normal level more than 3.3, then IV infusion or state according or plus minus state according to situation. Okay, after this condition, check regularly, and if the blood glucose is around 250, you have to start a neutralization drip in 5% NS, around 50 international unit insulin to maintain insulin around glucose around 200 to 250, and allow orally and take patient to subcute insulin. This is how you can manage such patient. Okay, I hope this clinical case and diabetic ketoacidosis will be easier for you. Thank you.